in this picture, you're seeing two gentlemen. One on your left is a typical old grandpa who's crouched using a walking stick to walk. And on your right, you've got a similar aged guy, but he's looking completely different. He's on a cycle. Let me tell you, he's my teacher. And this is a picture when he just cycled from Bombay to Alibag non-stop. So the question remains as, who do you want to be in today's generation? Would you want to be like the old duck in the left, or would you want to be an active, fit old guy? So things in today's generation are changing. People are wanting more and more to do with their lives. Things are changing from palliative treatment to preventive treatment. Now, nobody is talking about how to cure cancer. People are like right now thinking, how do we avoid cancer altogether? Same way, life-saving procedures are reducing, and right now more and more procedures towards changing the quality of life is happening. So the people's perspective is changing. So what is the difference between the previous and the old? It's not the age, because both are of the same age. Then what's the real difference? Is it the gender? Is it to do with their genetics? Not really. The main difference between the two is the quality of their bone and their muscles, which is somewhat interlinked, and that is what I'm going to talk to you about. But before going to the topic, basic understanding of how the bone works is important. So as an analogy, a bone or bony cycle is just like a building under construction. There's constant generation, regeneration, something new, something subtracted, something added, that keeps going on. So let us have a cross section of bone. So if you cut open a spine or a bone, this is how it is going to look. It is typically made up of columns, beams, and mineral. So technically it's something like how your wall is. It has got columns, it's got beams, and it's got cement which is put inside. So that's how a normal structure of our bone is. You must have heard about a condition called as osteomalacia. Now, osteomalacia is typically where the quality of bone is going to reduce, which means what is going to happen is that the structure of bone is going to remain the same, but the calcium inside starts going away, which means it is similar to you having a wall wherein you have laid in the bricks, but you have not put in good amount of cement. So basically the yellowish bit went away, and that is basically what osteomalacia or demineralization of the bone is. Osteoporosis, on an other hand, is a completely different condition. Osteoporosis technically is a disease of the bone, wherein what happens is there is just not the loss of mineral, but you lose the lattice itself, which means it's not just that you've forgotten to put good amount of cement in the wall, you've also not put enough amount of brick. So on the left hand side, you can see a representative structure of the bone, wherein you can see the lattice or the structure of the bone, which is filled in with all these black spots, which is the calcium or the cement. Whereas on the right is a osteoporotic bone, where you see that both the structure and the cement have reduced. So what essentially it does, it diseases the bone and it makes it liable for fragility, fracture, or basically it makes it like something like a biscuit where you do this and it is going to break. So basically what happens in osteoporosis is there is loss of bony lattice, which means there is change in the quality of bone altogether. On the left, you have got a normal bone, and on the right, you see a bone of a 75-year-old lady with osteoporosis, where you don't have the structure, neither you've got the calcium inside. Okay. So that's basically what osteoporosis is. Eventually what happens is whenever pressure starts coming, these bones which are structurally weak starts collapsing, and that is basically called as insufficiency fracture. Insufficiency fracture are fractures that are happening in bones which are diseased, either because of either osteoporosis or it could be because of some other pathology. The dictum is, if a person is falling down from a standing height, that is called as trivial trauma according to the WHO definition, and a person who sustains fracture with a trivial trauma is most likely because of an osteoporotic fracture. All right, so let's discuss a bit more about this, about osteoporosis, and I'm going to throw in a little bit on, I'm going to touch how to treat osteoporosis. Now, the question might come in as, why are we talking about osteoporosis? Because a lot of times you don't understand that the results of a treatment depends upon a lot of things. The two important things where the treatment depends upon is the quality of the bones and the quality of the muscles. When the quality of bone becomes bad, that is the condition called as osteoporosis. Whenever a person gets osteoporosis, the muscles also becomes weak, and this condition is called as sarcopenia. So osteoporosis and sarcopenia come hand in hand, and when we are treating any orthopedic problem, you need both qualities to be good. Now next question comes as, why am I talking on osteoporosis? See, the important bit is that osteoporosis first is seen by those people who are treating the problems arising out of it. And the biggest brunt of osteoporosis happens in the spine, followed by the wrist and the hip. So these are the doctors who are in direct touch with these patients, and hence we are the ones who are talking about osteoporosis. So let's just one second. Kindly refrain from annotating. Yeah. So now many things can actually interfere the development of your bone and influence how the quality of your bone or skeleton is going to be. Okay. It could be genetic abnormalities. It could be nutritional deficiencies. It could be hormonal disorders. These are the things that causes some kind of bone problem. So some can be tall, some can be short, some can be fat, thin. You've got people who don't have good bony development, or who have got deficiency of bone production, like osteogenesis imperfecta and such congenital conditions. And there are other conditions like thyroid deficiencies, which indirectly affect the quality of your skeleton. But the most important and the most commonest bone disease is osteoporosis. So just to give you an idea about how bad osteoporosis is hitting us worldwide, and this is facts coming from literature, worldwide osteoporosis causes more than 8.5, 8.9 million fractures annually. So technically there is one osteoporotic fracture every 3 seconds. Technically that's more than the speed with which the corona is spreading. Osteoporosis is estimated to affect around 200 million women worldwide. Approximately 1/10 of the women above the age of 80, above the age of 60, 1/5 above the age of 70, and 2/5 above the age of 80, or more than half of the age above the age of 90 are going to be osteoporotic. Now, why women? Is because overall osteoporosis tends to hit women maximum. Now, women have got that extra hormone called as estrogen, which is beneficial in a lot of ways. It prevents them from cardiac problems. It keeps the bone healthy. But as soon as they hit menopause, there's a sudden dip in your estrogen level. That's why that influences the bone quality, and hence it is the women who are hit with osteoporosis fastest. There's also other environmental fractures which are associated with it, which we'll talk about. Yeah. Now, in the year, overall, around 75 million people in US, Europe, and Japan in total are affected by osteoporosis. In the year 2000, and that's like 20 years back when all of this was happened, there was an estimated 9 million new osteoporotic fractures. Europe and America accounts for around 51% of all these fractures, whereas the remaining happen in the Western, West Pacific and the Southeast Asian region. Which means that osteoporosis is as important as diabetes and and breast cancer and blood pressure. So it's not something that we can ignore, and it's coming on our face every day since the activities are increasing. In overall, 1 in 3 women over the age of 50 will experience osteoporotic fracture, and 1 in 5 men are going to get that. So a lot of us who are right now discussing on this and hearing all this at some stage in our life are going to get osteoporotic fracture. Overall, 61% of osteoporotic fractures occur in women, with a female to male ratio of 1:1.6. Around 75% of fracture occurs amongst 65% year group or more. 10% of bone mass in the vertebrae can double the risk of vertebral fracture. So, which means that if your bone quality just deteriorates by 10%, you're at double the risk of developing a fracture. It is projected that about 50% of all osteoporotic hip fractures will be in Asia by the age of 2050. In a study amongst Indian women aged 30 to 60 from low income group, BMD reported that as compared to the developed country, there is higher prevalence of osteopenia and osteoporosis in our country, which means that Indians are at a higher risk of developing osteopenia and osteoporosis. In 2010, an international report in the Asian audit by International Osteoporosis Foundation had predicted that India would have approximately 36 million osteoporosis patients by 2013. But more serious was the fact that Indians are prone to fractures at a much younger age than their Western counterpart. The endocrinologist Dr. Amrish Mittal, who was a man who actually got the first bone density machine in India, predicted that 50% of the world's fracture were expected to occur in this region by 2050. The idea of throwing all these statistics on you is basically to prime you how much of a serious problem osteoporosis is going to be. And all of us are at that position where we can identify and treat osteoporosis quickly and effectively. Again, eventually towards the end of the lecture, you'll realize how important it is to follow correct protocols in treating osteoporosis, because these patients, before going to the endocrinologist, before going to the physician, are going to come to you and me. So it's up to us to identify them. Yeah. Now, the combined lifetime risk of hip, forearm, and vertebral fractures coming to a clinical attention is around 40%, as good as a cardiovascular disease. Also, osteoporosis takes a major economic and personal financial burden, because whenever you get osteoporosis, overall your productivity goes down. If you land up with osteoporotic fracture, that's an added expense, and that hits the entire family. So lot of places, especially now even in our country, where public health is given importance, they look at how much a disease is going to cause problem to the community. And essentially the disability due to osteoporosis is greater than that is caused by cancers, or is as good as any other disease such as rheumatoid arthritis, asthma, and high blood pressure. Now, you know about all these things, so you should know about osteoporosis also. In women around 45 years of age, osteoporosis accounts for more days spent in the hospital than many other diseases, including diabetes, myocardial heart attacks, and breast cancer. It is estimated that residual lifetime risk of a person experiencing an osteoporotic fracture in men over the age of 50 is up to 27%, which is higher than the risk of developing prostate cancer. And prostate cancer is one of the biggest screening campaign that happens in men. So if you are treating blood pressure, if you're treating diabetes, if you're treating heart problem, you have to treat osteoporosis. You don't leave it as a secondary disease, not giving them a lot of importance. All right. So let's say these are the commonest things that we hear about osteoporosis from. Even sometimes we think, or our patients talk about it, that doc, I'm taking calcium, I'm not going to get osteoporosis. Or some person comes and says that, doc, do something, my knee has got osteoporosis. So here are some facts about osteoporosis. One, osteoporosis is not calcium deficiency. Okay. Calcium is not the treatment of osteoporosis. Remember what I told you about the bone mineral and the bone mass. So again, just recapping, imagine you have a wall. A wall has got bricks inside, and on bricks you are putting cement. So a wall with good amount of bricks and good amount of cement is a normal bone. You remove the cement from that and your bone mineral goes down, and that is osteopenia or osteomalacia, where the quality of your bone is the calcium content of your bone is going down, but the structure of the bone is still the same. Condition where apart from the cement you have also removed some bricks. That is the condition where you get osteoporosis, because then how much ever cement you are going to put, if there's no bricks, the cement is just going to wash away. Similarly, how much ever calcium you load in a person with osteoporosis, it's not going to have any value, because the calcium is just going to get washed away. Second, osteoporosis is a generalized disease. It is not like you have osteoporosis in the wrist or you've got osteoporosis in the spine. It is affecting all the bones of your body. The fractured bone is just where you can actually see that disease with your eyes. Means the disease has caused a problem and you're identifying it. Does not mean that your the bone of your skull is normal. Even that has gotten weak. So it's a generalized condition. Again, the last bit is osteoporosis has got no cure. That is why it is very important that you identify it early and prevent it, because prevention is the only true treatment of osteoporosis. Okay, that is why early diagnosis is the most important step in treating osteoporosis. We guys are at the position where we can identify, counsel, screen, and test the patients for osteoporosis, and if detected, treat them aggressively. Okay. Yeah, just give me a second. So how do we diagnose osteoporosis early? So here what you have to do is clinically identify the patients who are at risk to develop osteoporosis, or someone who's complaining of these generalized aches and pains, generalized feeling of tiredness. Doctor, इधर भी दुखता है, इधर भी दुखता है, कमर भी दुखता है, पीठ भी दुखता है, ताकत नहीं रहता है, थकावट लगती है. These are the patients who are giving the history suggestive of a generalized bony problem. Or you identify those patients who are at risk. So patients who are taking, there is a big chart, but in general, patients who are taking steroids for a long term, patients who are fat, not really exercising a lot, are having a very sedentary lifestyle, has had history of fractures, are taking certain medicines which are prone to cause osteoporosis. So these are the patients. Clinically, these patients typically present with progressing kyphosis or generalized hunching. You will see that they have got muscles which are flabby, and overall the posture is ekdam weak. So these are the patients that you look at them and then you start thinking that, okay, maybe this patient has got osteoporosis. So a lot of patients who you all are treating for back pain who are not getting better in spite of everything that you do, maybe you have just missed out the fact that the patient is purely osteoporotic, which means the patient has got sarcopenia also, which means that the bones and muscles are weak, which means how much ever you treat them, the muscles are never going to get strong and their back pain will never go away. So this could be that one missing link in your treatment. That is why you identify the patients who are at risk for osteoporosis. What do you do then? Once you know that, okay, chalo, these are the risk factors, then you need to have some objectivity. Just because I said that the patient has got osteoporosis or some x-ray saying osteoporosis, does that mean that the patient has osteoporosis? Not really. So there are just two investigations which are there, which have also recently come up and we are looking at it, is DEXA scan and quantitative CT scan. So these are the two investigations which objectively can tell you if the patient is osteoporotic or not. Yeah. Just to give you an idea of how much the osteoporosis gets unrecognized, this is a series of patients. So what in this study it was done that around 930 women who are above 60 who were hospitalized for other causes other than spine related back pain. Yeah, they usually get chest x-ray done as protocol when they get admitted, and on seeing the chest x-ray there were around 130 odd patients who already had fractures, and there were 52% patients who already had some kind of some kind of mention of osteoporosis, which means up to more than 50% of people are roaming around without being recognized as patients of osteoporosis, which means that incidentally when you're doing an x-ray you suddenly see, array, the patient has got a very poor bone quality. So a lot of times even we when we get an x-ray done for some other thing, we see and we tell the patient, yeah, everything is fine, but I also see that your bone quality is bad. So that is why you should have a very high index of suspicion and you should have your criteria set as to which patients you are going to investigate for osteoporosis. Now, in my practice, what I usually, sorry, just 1 second. Yeah. So in my practice, usually every patient who is above the age of 50, females, and every patient who is above the age of 60, male, coming to me, I counsel them and I tell them to get a bone density report done. because it's my duty to educate people and try to pick up those patients. So I would also encourage you all to do that. Every patient above 50 who are females and 60 who are males should be at least screened once for osteoporosis. So you just tell them to get the bone density done. Now, who are those at-risk subjects? I just told you about this. There's a list of conditions where osteoporosis are seen. But for you, it's just very simple. Just identify those two patients, or patients with generalized aches and pains, or who are kyphosis. Sometimes the patients might also give you a very funny history that I feel my mom's height is reducing. Okay. You might laugh at that, but that actually happens. People who have osteoporotic fractures slowly and steadily become kyphotic. So slowly their height actually starts decreasing till overtly you can see kyphosis, and then the people know that they have started bending. So these are the histories that you have to look for. Once you have identified those at-risk patients, you send them for a bone density scan. So bone density is basically a dual energy X-ray absorptiometry scan, which means DEXA scan. It's a simple, easily available, relatively cheap test, and it's not something where you put the patient through a tube, which means it's relatively open. So it does not cause claustrophobia. It is a very good screening test, and it can also help in determining the response to treatment. Yeah. Sorry, just a sec. So here, once you do the DEXA scan, what do? Is we get two values. One is the T-score and Z-score. So let's say they have done a bone density of me and they have found some value. That value they are going to compare with normal healthy subjects, and they will tell how bad is my bone as compared to the normal healthy subjects. Okay. Z-score, on the other hand, will measure my bone quality with someone who they consider normal of my own age. So technically, and so these are the technical aspect, but practically it is the T-score that we are looking at, because we want to compare ourselves with the normal healthy. Okay. So you get a T-score of minus 2.5, which means that as compared to someone who is normal, my bone is minus 2.5 times bad. So technically, when your T-score is less than minus 1.5, you're considered to be osteopenic. And when it becomes less than minus 2.5, then you're considered to be osteoporotic. Okay. But there is a problem with osteoporosis, problem with bone density. One is that it's not like you start treating osteoporosis immediately, there's going to be a change in your bone density. So it's going to take time. Hence, you are not able to immediately monitor if your treatment is working correctly or not. That is first flaw. The second flaw is bone density basically is rays which are passed through the bones, and they are collected, and the quality of the bone is determined. In a severely degenerative spine, what happens is there is a lot of movement that is happening that causes osteophyte formation. If there is severe degeneration, severe osteophyte formation, which means there is a lot of new bone formation. So although the patient might be severely osteoporotic, your bone density will come normal. Hence, when you do bone density, you just don't screen the spine. You see three places which are affected the maximum. One is the spine, one is the hip, and one is the wrist. There is no role of full body DEXA. These three areas are good enough. If suppose a patient has been operated at a particular area, that area you have to just mark. You don't consider that area, whatever the reports are. Okay. And if you have got a very degenerative spine, so 80-year-old person showing T-score of 1 is something abnormal. There you see the X-ray, and if you see that there's severe degeneration, don't look at the spine. You look at the wrist, and you'll realize the wrist is minus 4.5. Okay. So that is the second problem. Now, the other thing is that not necessary an increase in BMD may not be an adequate surrogate marker of efficacy of all treatment, which means that even if your bone density quality is increasing, it is not just one second. Yeah, so you're not really sure is how much it is going to translate as a practical relief to a patient, which means your bone density might improve from minus 4.5 to minus 2.5 or minus 2, but that does not guarantee that he will not have fractures. So these are the fallacies of the investigations for bone density. So what else? There is another much more specific and better investigation for identifying bone density, and that's qualitative CT, which means you do a CT scan of the spine and you actually study the sections and see how much is actual bone density. So it will give you an accurate idea about the quality of bone. So that's one of a that's a very specific test. But the issue is that till now we don't know what is normal, which means if a QCT says that there is 30% bone density, what does that mean? Is it normal? Is it low? It is high? So we don't still have the baselines yet, because there are a lot of ethical problems in doing those studies, unnecessarily telling normal people to undergo CT scan. So that's still in progress. So as of now, the best possible test that you have to identify and evaluate and eventually monitor the treatment of osteoporosis is bone density. Okay, whenever you ask a person to do a bone density, ask them to do it after stopping all calcium supplements for at least 4 days. Okay, and tell them that you need the bone density level at the hip, at the spine, and at the wrist area. All right. So just before we start with the treatment, I have one urgent thing that I have to look at. Yeah. Sorry, some urgent messages. Yeah. So now once we know, once they have identified, once we have quantified everything, now we need to treat osteoporosis. So and as I told you, osteoporosis is a disease of the bone, which means that it is a medical problem, which means it has to be treated with medicines. All right. So the different treatment modalities are hormone replacement therapy. Then you have got raloxifene, calcitonin, bisphosphonates. There are newer medicines which are there. There are certain hormonal therapy like parathormones and strontium. So these are all the treatments that you have. Out of this, hormone replacement therapy and raloxifene and strontium, that has reduced or that has gone into disrepute, because when we started identifying the pros and cons of this versus that, we realized that the side effects of all those therapy was way more than the effects of those therapy. That's why they went into disrepute. And today, the three medicines which are used to treat osteoporosis are calcitonin, you've got parathormone analogs, and you have got denosumab. Yeah, not bisphosphonates. That is the main difference, which also I want to understand. So tell you guys. So a lot of people say that I have been taking Gemfos or I have been taking this medicine for so long, so I've been treating osteoporosis. Well, that's not the fact. Every medicine has a different way by which it acts on the body. So the first treatment which came into became popular and went into disrepute was hormone replacement therapy, because they started seeing that a lot of cancers started worsening or started the incidence of cancer started increasing in females who were taking hormone replacement therapy. Somewhere to do with the fact that the chances of breast cancer before 50 and after 50 varies, because mainly it has to do something with the estrogen hormone. Similarly, when you're giving hormones to a patient, you are bound to have side effects, and one of the side effects was cancers. That's why it went into disrepute. On the other hand, the things that we are using now are nasal sprays, which is one of the first and the easiest treatment. It is essentially a calcitonin nasal spray, which basically acts by inhibiting osteoclastic activity. And it has some action on the osteoblasts, which means that it demonstrates new bone formation effect due to direct anabolic action. Also, it has got a painkiller, somewhat of a painkiller action, means analgesic action. So what does this really mean? Now let's consider a bone. If you've got this bone, you have got osteoclasts which are there, which will come and which will eat away the bone and take the calcium and throw it into the blood. You have got osteoblasts which will take the calcium and reform the bone. Okay, so this is why the bone is constantly undergoing a cyclical change, thus like a building under construction. That is why when you use calcitonin nasal spray, it has action on osteoclast, which means it will stop the body cells to remove calcium from the bone, and it will stimulate the osteoblasts to deposit more and more calcium. Now the question comes as to why does the body want to do something like this? So calcium per se is very important for natural functioning of all of our cells, which means if your calcium in your blood goes down, your cells are going to start acting haywire, and one of the effect that will happen is you will end up getting a heart attack. That is why body has to primarily maintain the blood calcium level as normal. That is why a lot of times when people say, I don't have osteoporosis, my blood calcium is normal, the blood calcium is always going to be normal. That is the job of the body. That is why when you take in less of calcium, what happens is the body is taking away all the calcium from your bones, and the quality of your bone starts depleting. That's why throughout life after 50, you need to put a patient on a basic calcium supplement, so that at least you are artificially giving calcium and keeping the blood calcium level all right, so that at least the bones don't get destroyed. So calcium after 50 is not to treat osteoporosis, but is to prevent osteoporosis. Okay. Next, so primarily it is used in patients who are symptomatic patients with osteoporosis. Why? Because of the third property, that it also has a pain killing effect, which means a patient who has got osteoporosis and has a fracture or has bony pains, you give them, it really helps reduce their pain. And it also given in young patients. So nowadays we are also seeing young patients with low bone density value. So in young patient, it really helps a lot, and of course has a painkiller effect. It has a quick action. It is given through your nose, and the only problem is that you cannot give it more than 2 months, because after 2 months it develops an antibody to the. So basically, what is this calcitonin? It is basically an artificial animal derivative that you're putting in your body, and it is stimulating your bone production. Your body develops antibodies to it, and at some stage it stops working. That's why you give it only for 2 months. Yeah. The other is bisphosphonate. So as I told you, the treatment of osteoporosis is only three. There's calcitonin, you've got denosumab, and you've got teriparatide. But the most commonest treatment of osteoporosis given all around is bisphosphonate. Now, bisphosphonates are basically alendronate, residronate. In a trade name, it is called as Fosavans or Gemfos and all Hydrofos, all these things. Yeah. But they are not to treat osteoporosis. They are medicines to prevent osteoporosis. So its action is not to stimulate bone deposition. It only inhibits the osteoclasis, which means the osteoclasts, or those people who are removing the calcium from the bone. Bisphosphonate is going to go and stop them. So in a normal bone, when you give bisphosphonate, then it will prevent it from becoming osteoporotic, or it will delay the spread of delay the time by which the patient will really become osteoporotic, but it will not reverse the process. Understood? That is why up till now nobody bothered with osteoporosis, is because up till now the only treatment stopped here, and that is bisphosphonate. And if you don't have a treatment for a particular condition, then what's the point in treating that, or what's the point in even talking about it, right? So if suppose you don't have treatment, DEXA करके क्यों time waste करने का? That is why our previous generation, so our great grandparents or our grandparents, if you see, are all crooked like this, is because when they were growing up, there was no treatment. We are in the era where we can identify and treat osteoporosis. So up till now, we just discussed on identification and preventing osteoporosis, right? The actual treatment is reversing osteoporosis, which now for the past 10 years we have started, and now it's become safe. So that I'll talk to you a little bit in detail. But bisphosphonates you all need to know about, because that's the first line drug. And every patient who becomes osteopenic, which means every patient who on DEXA shows minus 1.1 or worse, should be started on bisphosphonate, because it is one, it is effective, it is compliant, it is not expensive, it is safe, except there is just one problem, and it causes a lot of gastritis. So every patient who we advise bisphosphonate is supposed to be told that you take it once a week in the morning and you take it on an empty stomach with cold milk or cold water, and at least 1 hour, don't lie down, otherwise you'll get a lot of gastritis. Okay, so that's bisphosphonate. It's a good startup treatment in osteoporosis, especially the post-menopausal women so a lot of gynecologists just start this for their patients as a preventive treatment. It works well till the bone stock is not very low, essentially. And there are certain conditions, like I don't want to confuse you, but there are certain conditions where there's a very acute bone loss. Those patients, bisphosphonate is going to help you a lot. So also, most of the studies that were done was done on the weekly dosage of bisphosphonate. So don't get carried away and try to give one injection a year or once a month injection. All the studies have happened at the weekly dose, and that's the most effective and the most safe way of giving it. And that's called as alendronate. Okay. Trade name is Gemfos 70 milligrams or Fosavan 70 milligrams. Okay. These are the advantages of bisphosphonates: is effective, widely applicable, good compliance, safe, and relatively cheaper. Okay. What about patients who have already got osteoporosis, which means their bone quality is already bad? The workers have come and taken away the brick over there, and now you are in a position to put in cement. But how to regenerate that, right? How to change and get the previous structure of the bone so that the calcium can get absorbed correctly back. That happens by two medicines, and that is teriparatide and denosumab. So this is the major change that has happened over the past 10 years that has made us capable of treating osteoporosis, right? So teriparatide or PTH in regular dose causes bone resorption, okay? Which means there are certain conditions like Brown's tumors, which secretes PTH, which causes bone to be resorbed, which means it worsens the osteoporosis. But if suppose we give it in a smaller dose and in a pulsated dose, which means single small dose at a regular interval, which means every day regularly for 1 year, ideally for 2 years, will stimulate bone production. And this is the only drug which can reverse and cause osteogenesis. Okay. So how is it different from bisphosphonate? Just conceptually to understand is, if you have a normal bone, that bone in osteoporosis gets resorbed. When you treat that patient with bisphosphonate, what it does, it prevents the further loss of bone, but it is not going to change your quality of the bone. Whereas if you treat the same patient with the help of teriparatide, what it does, it builds up the quality of the bone, one, and then the calcium deposits on that, and overall the end result is a very strong bone. So that is basically the main difference between preventing and treating osteoporosis. I hope I am clear as much as I could help you out with, right? There are other drugs also. So now teriparatide is a very safe medicine. It is similar to insulin, which you take every day. It comes as a pen vial, which you have to inject. Okay. These medicines range from 3 to 4,000 to around 20,000 a month. So it is expensive, and there's a great variation. Now, great variation is because all the studies have been done on the drug by a company called as Eli Lilly, and the trade name is Forteo. Okay. And then you have got Indian companies which have copied it and made it into their own versions. All right. It is not the drug or the company that's different. The problem is the effectiveness of the treatment depends upon cold chain. So this is actually a hormonal treatment, which means right from the production till the patient ejects it, it has to be maintained at a particular temperature. All right. So not all companies are, compliant with the norms. That is why some drugs, some injections, although they are very cheap, okay, you don't get the results. That's why we always advise that if you are affording, then you go for the original molecule, because as clinician, we have visually seen a gross difference between the result of Indian and the imported ones. All right. So here it is important to stick with the original molecule. Yes, of course, if the original molecule, if they are not affording, then you better give them the Indian molecule and make sure it's of a reputed company. Now, why so much fussiness is because there is a time frame. you cannot give this medicine for more than 2 years. All right, which means you start taking this medicine, you can take only a total of 2 years course. Beyond that, it is not safe to take this medicine. That is why you don't want to mess with it. You want to give the best quality. Also, the best effect is seen if you take this medicine every day for 2 years. I usually give it for 1 year and reassess the effectiveness of treatment. But the ideal protocol is you give it straight for 2 years, and then once the bone quality is built up and the quality is good, then you stop bone loss by putting in bisphosphonate. All right. So up now, that is teriparatide, and that is working only for 2 years. What about patients who are partially treated but they still have osteoporosis? They have not gotten totally better. What to do for them? 2 years of treatment is already done. So newer medicine called as denosumab has started coming in, and denosumab is a newer generation medicine that helps in osteoporosis. And the advantage of this medicine being that it has to be taken as one single injection every 6 months, and it is seen to be safe for up to 10 years. So the only disadvantage of denosumab is that it does not take care of sarcopenia, which means that when you treat osteoporosis with teriparatide, along with making the bone strong, it also makes the muscle strong. Whereas denosumab will only make the muscle strong. So you identify a patient. If the patient has got osteoporosis, you start giving them injections of teriparatide and make sure that they take that for 2 years without break. After 1 year, you repeat the DEXA and you see that is improving. If there's a substantial improvement, you can stop the teriparatide and shift to denosumab and keep that 1 year of teriparatide for a later date. If there's not a substantial improvement, you continue with the teriparatide. Okay. Once you shift to denosumab, you have to give it straight for till the time the bone density value improves. And once it is shifted from osteoporosis to osteopenia, that is the time you stop all of this and you shift to bisphosphonate. Now again, bisphosphonate you can give safely, but you cannot give it unendingly, which means you have to give it for a maximum of 4 years, after which you need to take a drug interval of 6 months. Otherwise, there are known that the subtrochanteric fracture of the hip drastically increases on a patient with long-term therapy of bisphosphonate. That's why you need to have a disease-free interval when you're treating a patient with bisphosphonate. All right. Multiple different trials were done, and after that, it has come that denosumab has now started emerging as a first-line treatment for osteoporosis, followed by teriparatide and prevention with the help of bisphosphonate. This is the medical basis to it. But apart from this, there are also environmental fracture that actually influences your bone quality. So diet is important. Just treating with hormones is not important, is not enough. You have to load yourself with calcium and vitamin D both. All right. Sunbathing is not enough for vitamin D, because in Bombay and in metro cities, the smog is so bad that you will not get that much good rays to develop good vitamin D from your skin. So vitamin D is important. Calcium is important. You need to take 1000 milligrams of calcium every day in a person with diagnosed osteoporosis, which is equivalent to 500 milligrams of elemental calcium. Never give vitamin D supplement without calcium. It is of no use. All right. But you can give calcium without vitamin D supplements. Apart from this, you need to be involved in certain physical activities, and because not exercising and not being active for long period increases the chance of osteoporosis. Like muscle, bones also become stronger and stay stronger with regular exercises, and these exercises should be a loading type of exercises where there is actual load that passes through your body, which stimulates the bone production in the areas of the load bearing axis, which means something like jumping, jogging, these type of activities. This is one condition which does not like you to be size 0, which means if you're too slim, then you better eat something, because it's seen that people who have very less BMI are more prone to osteoporosis. Smoking directly affects and causes osteoporosis. And again, alcohol, people who are alcoholics or who drink a lot are more prone to getting osteoporosis. So essentially the idea is that you should age gracefully, you should keep fit by identifying, treating, identifying, and if needed, treating osteoporosis, and coupling that with endurance building activities, exercises, and weight training. So the take home is that basically make the most of your growing years, recognize osteoporosis early, institute treatment early. You know, don't wait for it to happen. Treat it right in the beginning. All right. So that's basically all about osteoporosis from my side. If you have any questions, you can I can take them up. All right. I have just touched on the condition osteoporosis and the different treatment of osteoporosis. I have not really spoken about the surgical aspects, like what to do in surgeries of in patients who have got osteoporosis and we are opting for surgery, because that's a technical topic which you really, it's not really going to help you. But before we just finish, I'll just touch up on that. Is basically treating osteoporotic fracture is not like treating a regular fracture. You have to remember that the bone is diseased, and hence the bone is diseased, and hence you have to treat osteoporosis also, and you have to treat the mechanical bit also. Also remember that whenever you treat a fracture, just as a basic, what you do is there's fracture, you fix it. All right. The problem here is that where you're going to fix, that bone is also weak and poor, right? So what's the point? Like if the bone is weak, the screws are also not going to hold. So here the techniques of surgery varies a little bit, and we play around with cement, which is basically bone cement, which is a product which is similar to a bone, and which you can inject in a bone, and it artificially hardens the bone. All right. So I think this is all about osteoporosis. It was a nice and short talk. So we have enough time to take in questions and discuss all the confusions and all, anything that you want to ask from now, or your previous questions, you can shoot now. I have muted everybody. So if someone wants to speak, they can unmute themselves, or you can just type it out in the chat box. I'm going to give you around 5 minutes for putting up all your queries, so that then I start reading up your queries and then answering them one step at a time. Yeah. All right. So since we have some time on our hand, I'll start reading out some questions which have come to me. One question was that why do Indians have osteoporosis even when we have such great UV exposure? So osteoporosis, as I told you, that osteoporosis is not a lack of calcium and vitamin D. Osteoporosis is a condition where your bone quality is going to deplete. There are multiple factors associated with it. One factor, of course, is lack of calcium and vitamin D in your diet, but there are other factors like genetics. You have your hormonal component. So genetically, Indian population is different than the Western population. So there are certain factors over there where we'll look at. And one major reason why Indians are more prone is culturally, Indians are not into exercises. Means you never, now our generation is really into exercises. You'll never hear your parents or your grandparents talking about being fit, or all those things. And where you are not into exercises, there is less actually loading activities, and hence there is less stimulation of new bone production. That is one of the reasons why Indian are more prone at osteoporosis. There is no indication of using quantitative CT at present, except if some endocrinologist wants to study in detail someone who's having renal osteoporosis or osteoporosis because of some major endocrine problem, where they are giving different types of treatment and they want to objectively see if the bone quality is growing or not. So for that person, you can do a QCT and then you can do a follow-up QCT and then observe if visually your bone quality is improving or not. That's the only indication of using quantitative CT at present. Next question is, how would a fracture go unnoticed? So fracture is basically different types, but essentially fracture is what? It is break in the bone. Okay. Why does it pain? Is because whenever there's break in the bone and there is movement, it is the broken bone which rub with each other, and that causes severe pain. The places where osteoporosis hits you is your wrist, is your hip, okay, is your spine. So you also have seen so many patients who have wedging in the spine. So when you see an x-ray, you see that multiple areas are wedged. Okay, so that patient will never give you an history that I have had a fracture, but that patient definitely will give you history of back pains. Now those osteoporosis causing multiple wedgings is the cause of that back pain. Also, sometimes when the fracture happens at the hip or the wrist area, it's the cancellous bone. So what happens is the bone breaks, and because the patient is still walking, it impacts with each other. Okay, so the movement over there reduces. Hence, the patient might not have that bad pain where he can attribute it to fracture. So a lot of times we see patients with a neck fracture of femur, but he's walking to your OPD because the fracture has impacted, right? So that's how fracture can go unnoticed in patients. But these are typically the ones which are osteoporotic fractures. Yeah. Why is BMD done for ankle at maximum? Because that's time pass. That's of no use. The ankle BMD machine is a chota machine which you can take everywhere. It is essentially a marketing gimmick. It is of no medical relevance. So don't bother about all those time pass BMD cams where they are going to screen your foot and ankle. Yeah. As you said, osteoporosis prevention is better than cure. Can you please tell what can be given to a patient? Yeah. So a female who is coming to you before 40 years of age, technically you don't need to treat osteoporosis in them. Okay. Because osteoporosis is going to hit females after menopause and males after 60. So what you do is you yearly tell them to get the vitamin D and vitamin B12 level done. Vitamin B12 for non-vegetarians and vitamin D for everybody. All right. And if the vitamin D is deficient, you give them a course of vitamin D and calcium. So keep that normal. You tell them to get involved in endurance building activities and in weight training where there is resistance. All right. So that person does not really need to go and do deadlifts, but they can take that small baby weights and they can do the exercises which can stimulate bone production. So that is what you give to a patient who is less than 40. Okay. Once the patient has been screened by you and they have osteopenia, then you give them bisphosphonates to prevent osteoporosis. And once they have osteoporosis, you treat them. Why are calcium supplements given in the prescription then? So you understood why calcium is given. Vitamin D. So do you know what really happens with calcium? Whatever calcium you eat goes to your tummy. From your tummy, it goes to your intestines. In your intestine, it's absorbed and it is then put in the blood. From the blood, it is used by the cells and the remaining calcium goes to the bones. So if suppose your dietary intake of calcium is less, okay, the body will be forced to use the calcium which it needs from the bone. That is why if you don't give calcium, none of the therapy is going to work. Okay. But if suppose you are not building up your bone quality, then how much ever calcium you take, it is not going to go and stick over there. It will wash away. That is why building bone quality is also very important. Okay. Bisphosphonate should be continued not more than 4 years at a stretch, and after 4 years, 6 months break. Okay. Patient whose symptoms of kyphosis generalized. Yeah. So kyphosis will not reverse with exercises. Okay. Kyphosis is basically a deformity of the bone because of wedging, wherein the spine has started crouching in front. Once that has happened, it is not going to reverse itself, but the symptoms of kyphosis, which is back pain, will go away as soon as you start strengthening their muscles and treating osteoporosis. No, each and every person should not get calcitonin. Calcitonin is supposed to be given to patients who have osteoporosis, which means either they have osteoporotic fracture or they are diagnosed with osteoporosis. Those patients, you give them calcitonin. All right. Every 6 monthly injection. What about those? So denosumab, which I told you, is every 6 monthly injection, which can be taken maximum for 10 years. Initially, it was used to treat cancer patients, wherein if there's a liquidy cancer and you want to remove it from the body, you give them denosumab, make it calcified so that you can remove it easily. All right. So that's basically denosumab. Milk product is going to help in the diet, but technically there are a lot of schools of thought which say that milk is not mandatory. So you can survive your entire life without taking milk, without having any other problem, as long as you have enough calcium from other dietary sources. Okay. You cannot give teriparatide for more than 2 years, is because it basically causes newborn generation. The effect that it has on newborn, it can also have such kind of effect on cancers or other cells. That is why up till now, up to 2 years, it is safe. We don't know if we give it for 5 years, will it start causing cancers here and there, like how it was with hormone replacement therapy. That's why up to now it is 2 years, but research is going on, and very soon you'll get safety efficacy also for a later time. And people who require prolonged treatment, Prolia is a very good option. Yeah. Young people, vitamin, no, it's not like young people or old people. It is like what the person has. Okay. If someone comes and tells you that a 35-year-old person is having osteoporosis, your eyebrows should go up and you should think twice, that does he really have osteoporosis, or it's just something that people are just saying. All right. So those patients you want to screen and all that, and if a young patient is diagnosed with osteoporosis, then you treat it as it is. Yeah. Vitamin D you can take for lifetime. Just remember, vitamin D is not as vitamin B12, where how much ever you take, nothing is going to happen. Hypervitaminosis D also has consequences. So ideally, you should, in a deficient patient, you should take vitamin D once a week for 6 weeks. After that, only once a month you should keep taking, and you have to keep taking that for life. 60,000 units. Yeah. There is no calibration in a bone density machine. All right. So it is not like it is calibrated for Indian patients or imported patients or that way. By now, it is known that a person who has got a normal bone quality should show a DEXA rate of minus 1.1. More than minus 1.1, and osteoporotic patients are less than minus 1.25, minus 2.5. Yeah. So this is standard calibration, right? So it's not like it's calibrated specifically for Indians. But the problem is that how do you say that that person is normal? Just because we have considered that he doesn't have any clinical signs of osteoporosis, he is in the young age group, he's not menopausal, and he doesn't have any symptoms. But that still could be osteoporosis, which is subclinical. That's why comparison baseline is not very objectively identified. Still, the best way to identify, treat, and monitor treatment is doing DEXA scan, where you look at the T-score previously and T-score now, and you will know. And the report is very simple, self-explanatory, which will tell you if you're osteopenic or if you're osteoporotic. Yeah. I'm going to put the MRI presentation very soon. I just need to edit that a little bit, because we wasted around 25 minutes waiting for other people and all that. So that I'm going to remove, right? So transient osteoporosis. So that's probably a misnomer, because there is nothing like transient osteoporosis. It probably is something else which you have not understood, or it must be miswritten somewhere. Is there any? Because if you have osteoporosis, you have it. It can't be there for some time and then go away. Yeah, and X-ray cannot diagnose osteoporosis. So when X-ray tells you that there is osteoporosis seen, it's all digital X-rays. You cannot judge on that. That's why it's of no use to consider that. How long? Yeah, so technically every person above 50, forget every person in life should exercise, and that should involve core building, weight training, and endurance building, all three. Yeah, so it doesn't matter, but yes, every person after 50. So the community health talk that we do is to do that only, stimulate people to go and evaluate themselves and then start doing exercises so that so you guys can actually set up because you guys are directly in touch with the people, so you can actually set up osteoporosis awareness and osteoporosis camps where you can teach them exercises to prevent osteoporosis. Yeah. uh, uh, I think most of the thing. Yeah, so someone asked me why only wrist, hip, and spine is used maximally for bone density. Because the osteoporotic fractures are seen at this area commonest. Because spine is a load-bearing bone, wrist is a load-bearing bone here, and hip is a load-bearing bone. So maximum fractures are seen in this group. Is the reason why this area studied the maximum. Yeah, so that's the thing. You have to create. So some question was that how much calcium as a treatment for osteoporosis help. So by now it's self-explanatory that calcium is not the treatment for osteoporosis. Suppose if a patient is not taking calcium supplements, tell them you take this so that you don't get osteoporosis. But once you have osteoporosis, the treatment is completely different. So this is essentially one last question. If BMD is between -1 and -2.5, asymptomatic male 60%, can we wait with lifestyle changes? So you don't want to wait with lifestyle changes. The patient is coming in front of you. The yeah, so the patient is coming in front of you, male 60 years, with BMD in the osteopenic range. Immediately you start with lifestyle changing and start giving them bisphosphonate so that it does not worsen further, and do the test again after a year and see how much is the change in osteoporosis. If suppose it's become -0.8, which means you have successfully prevented osteoporosis from happening, and in that patient you can stop the medicines and just monitor it by doing once in 2 years bone density till a time comes that it starts worsening again. So that's basically, that is why you manage osteoporosis and not cure it. All right. uh, Technically no other real minerals are needed to be given along with calcium and vitamin D3. This too is good enough. Even ankle is a load bearing joint, we still shouldn't consider that. So ankle bone density is not being done. The bone density that is being done is of the foot. So when they actually put it on that, the levels that they give is of your foot bones, they are not giving of your ankle bones. Sorry, just 1 second, huh? Yeah. So vitamin D, if someone is deficient or if you want to just safely give vitamin D, the ideal dose should be 60,000 unit once every week. 60,000 international unit once in a week for 6 weeks, followed by once in a month for life. Along with that, you should give calcium supplements of 500 milligrams every day, or 1000 milligrams if the patient is diagnosed osteoporosis. What are the side effects of injections in patients with RA and osteoporosis? So injections given in rheumatoid arthritis are different. They are disease modifying anti-rheumatic drugs, usually given for ankylosing spondylitis and all, and that's essentially like chemotherapy. So there are a lot of side effects and everything. That's why those medicines should be only and only given by rheumatologists, because monitoring those side effects are very important. There are no real side effects of injections for osteoporosis, except when you start with teriparatide. In the initial few days, you will get flu-like symptoms, nausea, you'll not tolerate that, and It should not be given in patients who have had history of cancer which has gone to bones, because theoretically there is a risk that the bone cancer will worsen. All right. Sir, is there a recent trend where gynecs ask patient to take a break from calcium tablet? Is that needed? If yes, then when should that? So that's technically that ideally once in a year, 3 months, you should be off all medicines. But it is not based on any scientific study that I am telling you. I personally, if someone asks me for a break from medicine, I tell them to stop taking it for 3 months in a year. But ideally, only patients who are prone to certain kind of stones are asked to take breaks in their calcium supplements. Otherwise, it's all fine to take. Yeah, so now that you have asked about compression fracture of the spine, so I'll quickly just tell you what my protocols are in treating a patient with osteoporotic fracture. All right. So when a patient comes with an osteoporotic fracture in front of me, his clinical signs are going to be that of back pain, which is typically instability types, which means at a rested position, he'll not have pain, but turning positions and all, he is going to have pain. If it is an acute fracture, I am going to start the patient treating osteoporosis with calcitonin, some painkillers, and teriparatide, depending upon after doing all the blood tests and making qualifying him for surgery and everything, qualifying him for the injections and all. So once I start this, I tell them to start walking around within their pain limit and keep a watch. Usually by 3 weeks, the fracture should be relatively like the patient should be significantly pain free. If the pain keeps increasing or the instability type of pain is a lot, then I investigate in form of a dynamic x-rays. Mind you, x-rays are a dictum for all patients, but dynamic x-ray wherein I tell the patient to lie down and tell the patient to sit, and then see if there is any movement that is happening. And those patients, if there is no risk of neurological deterioration, still allow them to walk within pain limits and aggressively treat osteoporosis by everything that I told you. Repeat the similar investigations at around 6 weeks. Essentially, by 6 weeks, you should see that that movement should stop. As soon as the movement stops, you start with basic core activations and conditioning the patient, and wait for 6 more weeks, usually 3 months, and the patient is completely strong in terms of the fracture. All right. And after that, you start with the other things like aggressive exercises, preventive exercises, endurance building, weight training, all of that. Now, this could also be started at 6 weeks also if it's a small hairline fracture. Or sometimes the fracture might not unite and we have to intervene and either do a vertebroplasty, which means put cement in the body, or put screws and put cement in the body, or put bone in the body. So this is where we come into picture, where surgeons have to be involved. And the indications of surgery for osteoporotic fracture of spine are only two. One is neurodeficit, and two is instability causing severe pain and disability. So if teriparatide you don't give denosumab. If denosumab you don't give, then you tell the patient that for whatever reason you are not ready to take. For you, there should be no reason to not give injections. So you give teriparatide. They are not compliant. They say daily injection मेरे को लेना नहीं है. So give them denosumab. They say I don't want to take that also. Then say that sorry, no problem. Then we'll keep a watch and we'll wait for that day when you'll be forced to take this injection because you'll end up with a surgery because of a fracture. And they start taking that. What about age of patient? So actually, technically, age is not a bar in medicine anymore, because we are actually making patients 90, 95 years old also fit for surgery. So as long as there is indication, you take that. Yeah. So there was certain question about some throwing about vertebroplasty. So I'll tell you quickly what vertebroplasty is all about. Yeah. I'm just pulling out, trying to pull out some images from somewhere where I can actually try. Yeah. So can you all see my screen right now? Yeah. So can you all see this? So that's the representative model where there is one normal bone, other normal bone, and then there is a bone which has become wedged. So vertebroplasty is a procedure where a needle is put into the spine, and cement is used to fill up all that deficit that was there in the bone. So essentially, what is happening is you have normal bones, you have got bones which has become fractured, and on an x-ray you can see this small line over here. So that's completely empty. So in this patient, when you do a dynamic view, what you'll see is that the fracture is opening up and shutting like this, which means this is completely hollow from inside. So that is filled up by a white colored pasty liquid which is a consistently similar to bone, and this is what is osteoporosis. This is what is vertebroplasty in osteoporosis. Okay. So I think most of the questions have been answered. Sometimes it just does not fit into picture. There are patients who have osteoporosis at 20, at 30, at whatever age. But these are syndromic kids. So someone asked me about childhood osteoporosis. Childhood osteoporosis is essentially seen as a part of a syndrome like osteogenesis imperfecta or something, where there is some disease, where there's some genetic problem because of which the natural bone formation process is only disturbed. So these are all childhood osteoporosis, and they are a completely different ball game, which neither me nor you nor anybody we know are treating it. It is something that is specially dealt with by pediatrician, pediatric endocrinologist, and everything. Someone asked me, can teriparatide help restructure a hemivertebrae? So absolutely not. Hemivertebrae is basically a vertebra which is not normal. So a normal vertebra is supposed to be square, right? Hemivertebra is something that is not square. So it's growing from one side, it's not growing from other side. So it is not a disease of the bone. It's just an anomaly in the bone. But because what is happening is, if the bone is equally growing, your spine is going to grow straight. If the bone, there's a wedge over here, your spine is going to grow like this, and that causes scoliosis or kyphosis. But that is not a disease. So you don't, nothing will happen to it if you give teriparatide or not. All right. So in general, only in my books, there is no role of bracing. Like bracing is, out of 100 braces that you advise to patient, essentially only there is 10 which are indicated and 90 are for man ka shanti. Okay. But if at all you have to actually give braces in a patient with osteoporosis, then you have to decide why you're giving it. And if you're giving it for a fracture, then you require a complete brace, which means you require a TLSO, thoracolumbo-sacral orthosis, right, going up till here, so that it keeps your spine straight. Why? So that you don't abnormally load your spine like this and increase the osteoporotic fracture. No, no. Calcium supplements does not increase the risk of kidney stones. Who's going to get kidney stones are going to get kidney stones. And if you start thinking about it, not taking calcium because of the worry about the kidney stone, you're going to get in more disastrous problem than just some super stone. Yeah, so the thing is that since lot and lot more requests have started coming, we are nicely editing all the webinars that we have, and all of that we are going to upload on YouTube channels and send across the links to you all. Just that we are so busy with so many things, the surgeries and the emergency consults and the webinars, I've not really gotten a time for it. But as and when we have it, we'll keep sending it across to you all, and you can spread it across. Yeah. I think that's all for can get back to your Netflix thing or exercise or your painting or something, whatever you're doing right now. Meet on Sunday space because Chintan is going to talk on Sunday. I'll just give you the tone call. Just give me a second, yeah. So, Dr. Chintan is going to talk to you about all you need to know about shoulder stiffness treatment and diagnosis. Okay, so I'll send you the link soon in your WhatsApp and see you all on Sunday then. Yeah, bye. Take care. See you guys.